Thanks, Dr. Goldenberg. Thanks for coming this morning. So the title of my grand rounds is Distal Ureteric Strictures, Current Concepts in Diagnosis and Management. So briefly, this morning we're going to review the etiology of distal ureteric strictures, also talk a bit about clinical presentation and diagnosis, and also focus on treatment options, specifically minimally invasive treatment options, so specifically Endoureterotomy approach and then laparoscopic approaches as well. I'm not going to talk that much about open repair. So just a little bit of anatomy. The ureter can be divided into proximal, middle, and distal segments. The proximal ureter extends from the renal pelvis to the upper border of the sacrum. The mid-ureter is from the upper to lower borders of the sacrum. And the distal ureter is from the lower border of the sacrum to the bladder. Blood supply to the ureter is quite robust. In the abdominal cavity, it comes in off the aorta and the renal artery, whereas in the pelvis it comes off the internal iliac and its branches, superior vesicle, uterine, middle rectal, etc. The vessels course longitudinally and form this periureteral adventitia and a plexus. And this is advantageous because it allows the ureter to be mobilized to some degree without extensive devascularization. However, if this periureteral adventitia is stripped, then you can get devascularization. So some of the etiology, some of the benign causes of ureteric strictures include an impacted ureteral calculus, ureteral perforation during ureteroscopy. Things like endometriosis, abdominal aortic aneurysms have also been shown to cause strictures. Inflammatory and infectious causes include TB, schistosomiasis, sarcoid, and amyloid, as well as RPF, which is well known. Iatrogenic injury is a very common cause, especially during gynecologic surgery, which can be up to 75% of iatrogenic injuries. Some malignant causes, and these can cause obstruction either by intrinsic compression, infiltration, or lymphadenopathy. Malignant causes include TCC, cervical cancer, colon cancer, etc. Also, radiation for pelvic malignancies has been shown to cause ureteric strictures as well. So, seeing a patient who you suspect a ureteric stricture, typically you want to get a surgical history of stone impaction, and stone treatment. Also a history of any radiation, the timing of symptoms, perhaps during a diuresis or after drinking a lot of water. Also history of infections or any inflammatory diseases as well. Typically patients who do present with symptoms have flank pain or fullness, and these are sort of the most common presenting symptoms. They can also present with asymptomatic with an elevated creatinine and hydronephrosis. So imaging, typically, initial imaging could include a renal ultrasound, which is highly sensitive for hydronephrosis, but not that great for localizing the site of a stricture. CT with contrast is much more sensitive and specific for diagnosing hydronephrosis and the level of obstruction as well. Plus, you can look for stones as well as extravasation or perforation. MR has also been shown to be highly sensitive and specific as well, and is comparable to CT scan. And is useful for patients with any IV contrast contraindications. Retrograde pyelogram is very useful because you avoid IV contrast altogether. Also, you can analyze the details of the ureteral mucosa, and this can aid as a surgical planning tool and assessment for various endoscopic modalities like dilatation and endoureterotomy, which we'll talk about it in a bit. So one interesting study that I saw, and I don't think this is very used very often, but this paper looked at the use of an intraluminal ultrasound to diagnose ureteric strictures and also was used to assess treatment. So they looked at 63 patients with 67 ureters, and this was an observational study. And basically what they found was, based on the characteristics of the ureteral wall, this was thought to be a predictor to endoscopic management. So if you had a normal wall with just edema and no fibrosis, they didn't think any treatment was necessary. But if you had wall fibrosis but normal periureteral tissue, they found that this was amenable to endoscopic treatment, either balloon dilatation or endoureterotomy. But if you had extensive sort of periureteral fibrosis, they found that this was a poor response to treatment. They didn't actually give you any actual outcomes in the study. There was no sort of follow-up creatinine, but they just said the strictures had resolved, but they didn't sort of say exactly what they did to diagnosis. Again, this is sort of, it seems sort of like a limited observational study. I don't think it has a lot of use, and I've never really seen it, and it's not mentioned a lot in the literature, but I thought it might have a limited role during treatment. So nuclear renogram is commonly used, and you can get...
How many retrograde polygons have you seen? Pure retrograde polygons?
Sorry, how many retrograde polygons?
Have you seen, say, in the last little while? Have you seen anybody do retrograde polygons?
For looking for...
Without a procedure follow-up?
Yeah, out at UBC, I guess, I've seen, I mean, there was a handful when I was out there for a month, so, yeah. Patient with sort of, chronic indwelling stents. I think there was some patient with malignancy that had chronic indwelling stents, and there was some retrograde polygons done, so.
That's what I'm just saying, like,
Yeah.
like a diagnostic,
Yeah.
a diagnostic CMP. When's the last time somebody came in and you saw a diagnostic CMP?
Yeah, not for a couple months, but I have seen it a few times, yeah.
So it's not a common.
No, definitely not.
Compared to CTI,
Yeah.
or something else.
I mean, I guess with limited OR time, I guess a lot of patients are getting,
Yeah, that's what it comes down to.
yeah,
There was a,
yeah,
Jamie Richter, thank you, 14 a day.
yeah, yeah.
Mm-hmm.
So, oh yeah, sorry, so the question,
Go ahead.
okay. Nuclear renogram has been shown to have a role specifically for diagnosing renal function. There was a paper in 1997 looked at long-term results of endoureterotomy, and basically they had 9 patients who had complete failure, and they all had less than 25% renal function, and they'd all failed by 3 months. So they decided this was a marker of predictive marker of failure for endoscopic treatment. So your treatment options include observation, medical management, and surgical management, including endoscopic, laparoscopic, and open procedure. So patients suitable for observation, typically they're asymptomatic. They have normal contralateral renal function, but they may have poor function in the affected renal moiety, so maybe less than 25%. It is useful to try and temporize the situation with a nephrostomy tube or stent to get a real sense of the renal function on that affected side, and then a decision can be made based on that.
Dinesh, Dr. Wright was here to be talking about parenchymal width. We talked about that with salvageability.
Yeah.
Because once you've got an obstructed renal unit, and then you go and start introducing a foreign body with a nephrostomy tube and stent, and then you make a decision that you want to get that tube out,
Yeah.
and it's obstructed, and they get colonized, you're setting the patient up for a pilo or a pyelonephrosis. So it's very important to stop, think,
Yeah.
and then make a decision about whether you're going to do that, because you're overcalling the input you're going to get from a renogram,
Yeah.
rather than looking at the actual images yourself in terms of parenchymal width. Because if it's a blown out kidney and the kidney function is fine, the other kidney is fine, you may make a decision just to say leave it alone.
Okay. So indications for intervention include recurrent pyelonephritis, compromised renal function, pain, recurrent stone formation, and also the need to rule out malignancy. Stricture characteristics which are important when choosing your treatment modality include length of the stricture, malignancy, location, and again, renal function. So some of the open surgical treatments, I'm not going to speak to them specifically, but just to review them. For distal ureteric strictures, you can do a reimplant with or without a psoas hitch or Boire flap. Also a trans-UU, and then for strictures that are more proximal, ileal interposition and renal mobilization and autotransplantation. So some of the endoscopic treatments include stenting, either retrograde and antegrade balloon dilation, and also ureteroscopic endoureterotomy with either a cold knife, cutting electrode, or holmium laser. So stenting it can either be used as a temporizing measure until definitive treatment is undertaken, or you have more characteristics of the stricture. It can also be used as chronic treatment for other patients that are not suitable for definitive therapy, or they have a terminal malignancy. There is reported use of dual stenting, and there is, from the literature, caution about long-term stenting for extrinsic obstruction. But I'll talk to that in a few minutes. So one of the bigger studies on ureteric stenting was Wenzler from 2008, and they looked at 38 patients with intrinsic ureteral obstruction treated with indwelling ureteral stent. And all these patients were treated with no plans for any definitive management. And basically they analyzed the patients either as treatment success or treatment failure. And their goal was to identify any predictive factors preoperatively that would be used to determine which patients would be successful and which patients would fail. So their treatment failure definition was any ureter that needed an additional procedure, like a nephrostomy tube, but not a definitive procedure to treat the stricture, or they had persistent symptoms. And so their overall success rate was 88% at a mean follow-up of 25.5 months. There was 3 patients that failed management, and these patients were misdiagnosed. 2 of them had neurogenic bladders, and 1 of them had poor renal function to begin with. And the other 2 had outright stent failure. So of the patients that were successfully treated and had resolution, 13 of them went on to have definitive therapy. And this wasn't prompted by symptoms or treatment failure. They just decided to have treatment for their stricture. And the mean time to this therapy was about 3.5 months. 12 patients had resolution without the need for any stenting afterwards. And the mean number of stents were used in these patients was 2.3. And the mean time for resolution was 11.3 months. 11 patients had chronic stenting, and these patients had a mean number of 9 stents. And the mean number of time between stent changes was about 5 months. And overall, there was about 43.6 months these patients had stents. So they did a univariate analysis to determine the predictor of stent failure. And they found that male sex and increased serum creatinine as a presenting symptom, as well as degree of hydronephrosis, specifically moderate or severe hydronephrosis, was associated with a higher risk of stent failure. However, the study didn't present any information on the stricture length or characteristics. However, patients with no or mild hydronephrosis had 100% resolution of their strictures. There was another paper by Chung from 2004, and they looked at 15-year experience with patients who had extrinsic ureteral compression and stenting. The majority of these patients had cancer, either of the colon, rectum, breast, etc. So they found their mean follow-up was 11 months. 40% had stent failure, specifically persistent hydronephrosis, flank pain, increasing serum creatinine. And so from their study, they determined that a malignant cause of external compression was a significant risk factor for stent failure. However, 56% of the patients that did have a malignant cause were treated successfully. Other risk factors for stent failure included post-stent systemic treatment, such as radiation or chemo, suggesting progressive disease, and also an elevated creatinine at baseline. And these were all significant. So patients that had benign disease in this study did well. There was 11 patients, and 10 of them did well and had resolution. The majority actually went on to have intervention of their benign disease. In the study, they also commented that there was no correlation with stent size and failure of treatment. And there was also no correlation in this study between the degree of hydronephrosis and stent failure. So another study from 2009 looked at malignant extrinsic compression and the use of the metallic resonance stent for this. And so this is a nickel cobalt to alloy stent. It's got a continuous coil with an inner safety wire, and the flow through the stent is intraluminal, so it goes down the ureter. So they looked at 50 patients, and this was a prospective study. 25 of them had malignant extrinsic obstruction, and 18 had a benign obstruction. 7 patients had previously obstructed metal mesh stents, which had been removed. All of these patients were treated with the resonance stent, and then they had follow-up imaging. They defined failure in this study as increased hydronephrosis on a CT scan. So the patency rate in patients with malignant obstruction was 100%, with a mean follow-up of 11 months. However, patency rate for patients with benign extrinsic obstruction was much less, at 44%, with a mean follow-up of 6.8 months. And they cited that stent failure in these patients with benign disease was due to incrustation, or this hyperplastic reaction they saw, which was invading the stent coils, causing obstruction. So retrograde balloon dilation. Indications for this procedure include a short stricture or a soft stricture, and contraindications include active infection or a longer stricture. And typically patients are stented 2 to 4 weeks post-operatively. Balloon dilation initially was a procedure that required repeat balloon dilations, and it was not definitive, but with improvements in balloon technology like vascular angiographic balloons, it has shown some improvement. One of the earlier studies looked at the literature on balloon dilation, and their recorded success rate was 50 to 76%. They found favorable results for iatrogenic non-anastomotic strictures as well as short strictures, and the duration of stricture less than 3 months. Another more recent review of the literature looked at 8 published series with a mean follow-up of 10 to 29 months, and their success rate was quoted as 48 to 88% with a mean of 55%, and they looked at 280 strictures. And again, they concluded similarly that short non-ischemic strictures were the best treated with a balloon. So a more recent study looked at benign strictures in any segment of the ureter and classified it as both non-ischemic and ischemic causes. And they looked at a series of 114 patients, and their minimum follow-up was at least 2 years. So they looked at strictures and assessed them with an IV urogram pre and post-treatment, or a renogram if the IVU was inconclusive. And this was performed about 3 to 6 days after the stent was removed. Treatment success, again, was unchanged IVU or maintenance of a baseline GFR. So in this study, 81 patients had balloon dilation, and 27 had endoureterotomy, and 6 of them just had just stents. So they had identified that patients with a compromised vascular supply would be a significant factor for success with balloon dilatation. So things like stripping of the lymphatics from the ureter during surgery, bypass grafting of the aorta, long-standing abscesses or impacted calculi for more than 2 weeks. All these patients were stented post-treatment up to 4 weeks. So basically what they found was that balloon dilation was successful in 89.2% of the patients with a short stricture, so less than 2 centimeters, and had an intact vascular supply. However, if the vascular supply was compromised, the balloon dilation was less successful, and only 40% of these patients had resolution. For patients with longer strictures, more than 2 centimeters, only 37.5% of these patients had resolution, and 16.7% without vascular compromise had resolution.
Dinesh, how did you tell if they had a vascular?
Basically from the history and the cause of their stricture. So if they had, if this stricture was iatrogenic from sort of gynecologic surgery or on the list, abdominal aortic aneurysm, bypass, etc., then they precluded that this was, vascular compromise. So it was more based on history.
What would they consider a non-vascular compromise?
So I guess a stone, less than, shorter amount of impaction, or treatment, injury from ureteroscope, perforation, that sort of thing. Let's see. So this is sort of the list of things that they had defined as vascular compromise. I don't know how many blast injuries we get here in Canada, though. So for patients that had a short stricture and intact vascular supply, 4 of them had this endoureterotomy, and they all had resolution of their stricture at 2 years. 75% of patients with a long stricture and intact vascular supply, so this is a stricture greater than 2 centimeters, had resolution with endoureterotomy, and 83.3% had resolution with a compromised vascular supply. So this study concluded that balloon dilatation was best for short strictures with an intact vascular supply. So endoureterotomy essentially involves retrograde pyelogram and then direct visualization of the stricture, and can be done with a number of different tools, including a cold knife, cutting electrode, holmium laser, and cautery wire balloon. You get retrograde access, and you need to have a safety wire, and the incision needs to be made from the ureteral lumen out to the periureteral fat, so it needs to be full thickness. And it's been commented that you need to get at least 2 to 3 millimeters of normal ureteral tissue proximally and distally when you're doing this. A study from 2006 looked at the long-term efficiency of holmium laser endoureterotomy for benign strictures. This was a small, limited study with only 19 patients in retrospective analysis. All these patients had stents afterwards for 4 to 6 weeks. Mean stricture length was around 0.9 centimeters, and mean follow-up was 3 years. And again, they defined successful treatment as resolution of the symptoms or radiographic resolution. 68.4% of patients had treatment success at 3 years. They found the patients who failed treatment, again, had a longer stricture with a mean of 1.5, and this was statistically significant. They concluded that their results were similar to those previously cited in the literature of around 70 to 75%, but again, this was a pretty limited study by numbers. Another technique which has been mentioned is for complete obliteration of the ureteral lumen, the so-called cut-to-the-light approach. And this is a combined antegrade and retrograde approach. I guess basically you get a ureteroscope from above and below, turn the light off on one, and then try to either pass the stiff end of a wire through or laser to the light. And this requires fluoroscopic and direct vision. And then you can balloon the segment once it's opened. But again, reviewing the literature, it's not very commonly performed. There's one study from 2001 where they had 10 patients, and their overall success rate was 90% at 2 years, but only 3 of the patients had this so-called cut-to-the-light procedure. So I'm going to talk a bit about laparoscopic approach now to ureteroneocystostomy, and this includes laparoscopic psoas hitch and laparoscopic Boari flap, as well as robotically assisted procedures as well. So this was first described in 1993 for treatment of vesical ureteric reflux, and typically it's a transperitoneal approach and requires intracorporeal suturing or newer devices such as the endostitch. This has been quoted as a technically challenging study, but improvements in laparoscopic technology and technique have made this more feasible. An example of developments in technique, there was a study in 2005 which described their dome advancement technique, which was thought to minimize extensive bladder dissection and allow you to reach a ureter transected above the iliac vessels and preclude the need for a Boari flap. Basically what they did is they made an incision of the dome of the bladder 1/3 of the distance between the dome to the base anteriorly, and then they spatulated the ureter and sutured it to the midpoint of the incision. And the bladder was opened transversely and then closed longitudinally to get extra length. And they said that this avoided need for ligation of the contralateral pedicle. So the largest series on the laparoscopic reimplantation was Seideman from 2009, and they looked at 45 patients with distal ureteric strictures. 53% of them had a Boari flap, 47% of them had a Boari flap, and 53% just had a reimplantation. 8 of these patients had undergone previous attempts at repair, either balloon dilatation, open repair, or urethrolysis. So their success rate was 96% at 24.1 months, and this was no obstruction, no need for another procedure, and no renal deterioration or symptoms. 2 patients had recurrent stricture, with one having a nephrectomy in the end for chronic flank pain and pyelonephritis. Their mean intraoperative blood loss was 150 cc's, and length of stay was 3 days. They didn't quote any OR times, however. 3 patients had a leak postoperatively, but were managed conservatively with a stent and Foley catheter. There have been some studies looking at open repair versus a laparoscopic technique. One from 2007, which looked at 10 patients in each group. 8 patients in the laparoscopic group had a distal stricture, and the rest were mid-ureteric strictures. 9 patients in the open group had distal strictures, and the rest were mid-ureteric strictures. And in the lap group, there was 4 psoas hitches, and 6 patients had Boari flap. In the open group, 8 had a psoas hitch, and 2 had a Boari flap. So at baseline, there was no significant difference between patients. Mean stricture length was also the same, and there was no significant difference in mean operative time. However, blood loss, days to oral intake, mean length of hospital stay, and time for convalescence was significantly less. Another study looked at, So again, they went on to conclude that the mean length of the stricture groups was not significantly different, and there was no intraoperative complications in the laparoscopic group. Patients in the open group had 2 postoperative complications, urinary extravasation and a hematoma, and also an anastomotic stricture, but these were treated and had resolution. All these patients had imaging post-op, and all the patients in the laparoscopic group had resolution of their stricture. 2 patients in the open group had recurrent stricture and required stenting and balloon dilatation with eventual resolution. So another study looked at the difference between open laparoscopic approach for reimplantation, 12 in the laparoscopic group and 34 in the open group, and this was a retrospective study. Again, patients were similar at baseline. All patients were stented for 4 to 6 weeks, and again, patients were followed around 2 to 3 months with a serum creatinine and renal ultrasound or IV urogram. So this busy slide basically is to summarize that between the 2 groups, there was a similar percentage of procedures performed either a UU or a reimplant or a Boari flap, and also the etiology of the strictures were also similar in percentage. Also, again, there was no significant difference in stricture length between the 2 groups. So overall, again, the patients were similar at baseline. However, there was a significant difference again in blood loss. Also, hospital stay was significantly less for the laparoscopic group as well, which is consistent with the other study. So again, 100% of the patients in the laparoscopic group had resolution of their stricture with a mean follow-up of 23 months versus 96% in the open group. The overall complication rate in the lap group was 8.3 and it was 14.7 in the open group. There was no statistical difference for these 2 groups. 1 patient in the open group had a restricture with balloon dilatation, but eventually did have resolution. 1 patient in the laparoscopic group had a postoperative urinoma seen on CT scan, and this was a Boari flap procedure, but it was managed conservatively with bladder decompression and resolved in 2 weeks. So finally, robotic assisted reimplantation has been described, first in 2004 for ureteric injury following a radical prostatectomy, and then was described again in 2007. The largest series, which includes 12 patients, and this was performed in 2008, is a multi-institutional, multinational study for patients with ureteric strictures. 10 of them were distal. Again, the conversion rate was 0%, and there was no complications with a mean follow-up of 15.5 months. So their mean operative time was 208 minutes with a blood loss of around 48 cc's. Mean length of stay was 4.3 days, and all patients were stented again. All patients were asymptomatic at follow-up, and imaging was normal in 10 of the 12 patients. 2 had mild hydronephrosis, but this was not clinically significant. So conclusions, there's a variety of causes of distal ureteric strictures. Important characteristics of the strictures, though, include extrinsic versus intrinsic, benign versus malignant, stricture length and location, and also the patient's baseline renal function. Strictures of less than 2 centimeters, endoscopic management has been shown to be useful. However, if the stricture is longer than 2 centimeters or it's complex, open or laparoscopic management needs to be considered. So ureteral stenting has been shown to be a useful temporary solution or a reasonable option for short strictures without an increased creatinine or severe hydronephrosis at baseline. However, there was no clear evidence from the literature about the interval of stent change, and it seemed to be quite variable. Again, metal stents seem to be more effective for malignant extrinsic compression, but not as useful for benign extrinsic compression. Balloon dilatation is effective for patients with short strictures with an intact vascular supply, but less effective for longer strictures or a vascular supply that's been compromised. Holmium laser endoureterotomy is also effective for short strictures less than 2 centimeters with or without compromised vascular supply, with an overall success rate of around 70%. But again, the prospective data on this is quite limited, and there's only a small amount of studies with a limited number of patients. Laparoscopic reimplantation is technically feasible, and improvements in technique and equipment have made this an easier procedure. We've seen decreased intraoperative blood loss, less time in hospital, and less analgesic use, and a faster return to work. And this has been shown consistent in the laparoscopic literature. Finally, robotic assisted techniques are gaining popularity and seem promising, but further studies are required. And so far, they seem no worse than conventional laparoscopic procedures. So thanks for your attention, and I just want to say thanks to Dr. Chu for his help with this presentation.